Hello, this is Dr. Grant Cooper from Princeton Spine and Joint Center. In today's video, I'd like to discuss degenerative disc disease with you. Specifically, let's talk about what it is, what it isn't, how you know if you have it, and what you should do to both treat it and to prevent it. It may sound like a lot, but we're going to make it very easy and simple because in the end it is simple and easy, and you're going to see that as we go through this together. Also, you're going to realize that if you have degenerative disc disease, it's actually not nearly as bad or scary as it sounds. I promise. So what is it? Degenerative disc disease is a term that's used to describe the natural degenerative processes that occur over time in everyone's disc. Wait, did I say everyone's disc? I did. But if I did, then wouldn't that mean that everyone gets degenerative disc disease? And the answer to that is a resounding yes. If you live longer than 30 years, you're basically guaranteed of having at least some degenerative disc disease. And in fact, if you're fortunate enough to live into your 70s, 80s, and beyond, then you're guaranteed to have lots of degenerative disc disease. So given that everyone gets it, one thing that should become clear is that the word disease in degenerative disc disease is quite the misnomer. Really, degenerative disc disease describes a process whereby the discs experience normal wear and tear. To that end, I cannot tell you how many patients I've seen who come to see me and they tell me almost in a whisper that they've been diagnosed with, and then they sort of whisper, degenerative disc disease, as if it were a death sentence or some horrible disease. Now, almost to a person, when they tell me that they have, degenerative disc disease, I can feel them reading my face, expecting a horrified look or an audible gasp. Instead, as you can now imagine, I suppress a smile so they don't think that I'm not taking them seriously. And then I go ahead and I explain to them much of what I'm about to explain to you. And that is this. Over time, discs lose fluid through the natural wear and tear of life. As discs lose their fluid, they become more dehydrated, right? They also become less flexible, they lose their height, and they become flatter. You could think of the process as being a bit similar to the transformation of a warm, fresh, fluffy pancake going through, a transition that starts to resemble a somewhat stale crepe. This process doesn't happen overnight, but it rather plays out very slowly as the years and decades of life pass by. Now, a degenerative disc has consequences for the disc, and it also has consequences for the spinal structures around the disc. As the discs become stiffer, some of the mechanical forces that had been more easily accommodated by the disc are now translated to the adjacent structures, right, to the facet joints and the other spinal structures, which can lead to more wear and tear in them. Also, in the disc itself, there may be more of a likelihood that they end up becoming inflamed and painful. Now, note that the presence of a degenerative disc, or as they say, the presence of degenerative disc disease, doesn't mean that you'll definitely have pain. In fact, to be sure, most people with degenerative disc disease don't have any back pain. All right, let me repeat that for emphasis. Most people with degenerative disc disease don't have any back pain. Even in a person that has pain from a degenerative disc, the chances are that in this same person, that person is going to have 4 or more other discs that are equally degenerative that aren't painful. So what makes a degenerative disc painful or not? Well, 2 things. First, if the degenerative disc flattens and it bulges, then that can contribute to stenosis or narrowing of the holes where the nerves exit from the spine. Now, stenosis itself doesn't cause inflammation in the nerves, but stenosis means that the holes where the nerves exit, right, where the nerves are traveling, are now smaller. And this sets the stage for potential irritation and inflammation in and around the nerve. If the nerve becomes inflamed, then the person can have nerve pain radiating into the arm or the leg. Now, the more common way that we think of degenerative discs as causing pain is from the disc itself, right, by causing either neck or mid-back or lower back pain. When a disc causes pain, it's because there's a tear on the inside of the disc. Importantly, a tear on the inside of the disc, which is called an annular tear, can occur in a disc that on the outside looks morphologically normal. Now, a tear can also occur in a disc that we would say has degenerative disc disease, i.e. it's lost hydration and it's started to flatten. And of course, a tear in the disc can also happen in a disc that happens to also be herniated. When annular tears are painful, and note that I said when because they aren't always painful. We'll return to that in a moment. So when annular tears are painful is for the following reason. A disc is like a jelly donut. You may have heard that before. There's an outer crust of the disc, which is the annulus fibrosis. So there's the outer crust of the disc. And then there's the inner jelly over here. And that's called the nucleus pulposus. And the inner jelly is full of inflammatory proteins. Those proteins give the cushioning to the disc, but it's made up of inflammatory proteins that if they get next to nerves, they cause pain. But there are no nerves in the middle of the disc. Now, in the outer third of the disc, of the crust of the disc, there are nerve fibers. And when there's a tear in the disc, it kind of looks like a pie. And the jelly in the disc oozes out, and it can irritate the outer third of the crust of the disc where there are nerve fibers. Now, we say that that can cause pain because the tear doesn't always cause pain. In fact, if you see an annular tear on an MRI, it doesn't mean that it's causing any symptoms in the patient. It's consistent with the disc causing back pain or discogenic back pain, but it's not diagnostic of it. So what's going on in those instances? Well, the body's very good at managing its inflammation for the most part. So if the body scars down on itself when there's a tear, then the tear will still be present. And you can see that on the MRI, but there will no longer be those inflammatory proteins in the tear. Instead, what you would see if you were to go ahead and take the disc out and dissect it is that now that tear is full of scar tissue. So when a degenerative disc disease causes back pain, it's because there's a tear on the inside of the disc that's inflamed that's causing pain. Okay, so sometimes I see a patient who has no back pain, but they've gotten an MRI for whatever reason, and they were told they have degenerative disc disease. So they come in and they see me and they're nervous and they want to know what should they do about it. So what should they do, right? What should I tell them? They have no back pain, but they have degenerative disc disease. So first, I tell them that getting degenerative disc disease is a normal part of getting older, right? So by some studies, you can find degenerative disc disease in over 70% of the population. That's in people who have no back pain. 70% of them under 50 years of age, and more than 90% of them in people over 50 are going to have degenerative disc disease. So unless you're a teenager or maybe 20, then you're going to have degenerative disc disease. Put it another way, if you were 80 and you came into my office and we got an MRI and you had no degenerative disc disease, even if you had no back pain at all, you would be an absolute medical marvel. I would want to write a book about you. I'd want to send you to Mayo Clinic so they could study your blood and we could find the secret of your spine fountain of youth, right? That is to say, it just doesn't happen. Everyone gets degenerative disc disease as time goes on. And that's okay, because not everyone gets symptoms. It'd be different if everyone got symptoms, but they don't. So again, what should this person with no symptoms and a perfectly normal looking MRI for their age do about it? Now, actually, I don't tell them what you might think I'd tell them, which is to ignore it. Actually, what I always suggest is for these folks to take this moment as an opportunity. You see, most people, most of us, are going to have significant back pain and issues as time goes on. Sometimes that pain only lasts for a little while, but other times it can last a long time, even a whole lifetime if it's not treated. So the best way to deal with this fact is to get in front of it. Start working on prevention. Right? As Benjamin Franklin said, an ounce of prevention is worth a pound of cure. So what does prevention mean? It doesn't mean that you can prevent degenerative disc disease. You can't. You can't stop the wind from blowing either, but you can still build yourself a house so that when the wind blows, you don't feel it, right? And you can help support your spine so that the cascade of arthritic changes and potential for pain is much less likely. And the way that you can do that is with this magic pill, right? For just $9.99, you can buy a... No. No, you can't do it with a magic pill. There's no magic supplement. I can't tell you how many times I'm asked about that. But you can do a lot to prevent degenerative disc disease from getting worse. And you can do a lot to prevent ever having pain. And the way you do that is by learning a set of exercises that are specifically designed to stretch and strengthen the muscles around your spine. which in turn support your spine. Now, does this really work? Absolutely. You see, the spine is like a mast on a ship. You know how a mast on a ship has all those riggings, right, that attach to it? You know why those riggings with a mast are there? The riggings are there to support the mast. Without the rigging, the mast couldn't support its own weight. It would fall over. Now, the human spine, if you took it out of the body, it could support about 35 pounds of axial load, of axial pressure, before it starts to break. No matter how big or how small you are, you weigh more than 35 pounds. We all do. Even the skinny models on the covers of magazines like Vogue and Glamour, right? We all weigh more than 35 pounds. So we all rely on our muscles that attach to the spine to support our spine to help take the pressure off of it. And by getting our muscles strong and limber in the right way, we can unload the spine and help take the pressure off the spinal structures like the discs and the facet joints. In a way, it's sort of like an eat your vegetables moment, right? Except instead of eat your vegetables to make you healthy, it's do your exercises to protect your spine and make you stronger and fitter. That is, you should be doing some exercises, but you have to actually do them, right? And with exercises for the spine, it's a little different because you have to make sure that you're doing the right ones and you're doing them in a safe way. So it's not just exercise in general, but it's doing the right exercises. I've had professional athletes from as varied sports as American football to soccer to rugby, gymnastics, roller derby. Roller derby is a real thing. I saw a woman who was a very good professional roller derby athlete. She's one of the toughest women that you'll ever meet. But one thing that all these athletes had in common is that even though they were super strong and super fit, many of them weren't strong and fit in the right way to protect their spine. Right? So it's not just about exercising and having a strong core, for example, but it's about having the right kind of strength and integrating the strength of your core with your pelvis. It's not just having strong hip abductors, but it's about having those hip abductors turn on at the right time, and it's about doing the right exercises to accomplish that. So, if you want a good exercise regimen, you can check out our video on the best exercises to prevent back pain. Another great way to learn the right exercises is to work one-on-one with a great physical therapist. They can help walk you through the right exercises to help you prevent back pain in the future. Now, if the person is having back pain and they also have degenerative disc disease and they come to see me, then what do I tell them? Well, it depends, of course, right? Because remember that just because a person has degenerative disc disease, this doesn't mean that that's what's causing that person to have back pain. Maybe it's what's causing the back pain, but maybe it isn't. So how do we know? How do we figure it out? Well, first of all, if we're talking about degenerative disc disease in the neck, then degenerative disc disease in the neck is unlikely to be causing a person's neck pain. And this is because the most common cause of chronic neck pain in the neck is the facet joints, right? To the tune of about 60% of all chronic neck pain, with as much as 80% of all chronic neck pain in a person with a whiplash injury is coming from their facet joints. Degenerative disc disease is a far second causing chronic neck pain, accounting for about 15 to 30%, depending on the study. Now, clinically and on an MRI, facet joint disease and degenerative disc disease causing chronic neck pain are going to look very similar. So the way you prove that the facet joints aren't causing someone's chronic neck pain is by injecting the joints or injecting the nerve that innervates the joints with lidocaine. And if that block offers even temporary relief, then this strongly suggests that you found the source of the person's neck pain, and it's probably from their facet joint. On the other hand, if you block the facet joints and they don't get better temporarily from the lidocaine, then it's almost certainly not coming from the facet joint, and then the most likely cause becomes the disc. Now, in the lower back, the most common cause of chronic lower back pain is in fact the disc, accounting for about 40% of chronic lower back pain. Additionally, in the lower back, the symptoms can give a better clue as to the patient's source. So if the pain in someone's lower back is worse with sitting and worse with bending forward, and if the pain is better with standing and bending backwards, then this adds to the presumption that the pain is coming from the person's disc. On the other hand, if the pain is worse with standing, but it's better with sitting, then this suggests that the pain is more likely coming from the person's facet joints, which are the second most common cause of chronic back pain. Now, these aren't hard and fast rules, but they're consistent with the mechanics, and they're good rules of thumb to go by. When the disc is causing someone's neck or mid-back or lower back pain, what you're really treating at that point is the inflammation inside of the disc. That's what's actually causing the pain, right? It's the inflammation around the small pain fibers in the outer third of the crust of the disc, like we talked about. So, how do we get rid of that inflammation? Well, to answer that, we need to answer the question of what is inflammation. And inflammation is a protein response, but the best way to think about it is that it's like a fire. And there are two ways that we can put out the fire. The first is by clearing away all the fodder, right? Clear away the fodder from the fire and let the fire die down on its own. So that is clearing away the fodder to allow the body to lay down scar tissue in that annular tear so that that tear becomes an asymptomatic tear. The best way to clear away the fodder in the spine is with exercises like we were talking about. By stretching and strengthening the right muscles in the right way, we can unload the disc and allow it time to scar down on itself. Now, sometimes the pain itself prevents you from doing your exercises because it just hurts too much. Or you do the exercises, but the inflammation just won't die down, right? It just keeps on burning. If this happens, you may need to put out the fire with a fire hose. Now, in this instance, there are oral anti-inflammatory medications such as over-the-counter NSAIDs like Advil or Aleve or prescription-strength NSAIDs. You can even take oral steroids, which have a lot more side effects but are also a lot stronger as an anti-inflammatory medication. The problem with oral anti-inflammatories is that only about 2% of what you take by mouth is going to reach the site of inflammation in the spine. So unfortunately, it's just not very realistic to think that you're going to take a normal amount of medication and have a significant amount of that medication reach the spine, even with oral steroids. That's not to say that there isn't a role for medications. There certainly is. But taking oral medications, particularly NSAIDs, it's mostly about controlling pain as opposed to fixing the inflammation at the site of the spine. The best fire hose is going to be a targeted X-ray guided or fluoroscopically guided transforaminal epidural steroid injection where the medication can be delivered directly to the site of inflammation. Now, this is going to be particularly effective when there's a full thickness annular tear that extends through the entire annulus. This sort of injection delivers anti-inflammatory medication directly to the site of inflammation where that annular tear is. It generally takes a few days to a week or 10 days for the steroid medication to be metabolized and work. When it works, and of course nothing in life always works, but when it works, the inflammation goes down and therefore the pain gets better. Now, importantly, the pain is not masked when an epidural steroid injection works. That is, you aren't injecting a numbing medication to anesthetize the disc. What you're doing is you are in fact taking away the inflammation, which is what was causing the pain. But you also aren't addressing the biomechanics that led to that inflammation in the first place, where you aren't improving the hydration of the disc, you aren't changing the core strength of the person or the flexibility of the muscles. So when injections are used, it's important to think of them as more windows of opportunity that allow the patient, while the inflammation and pain are gone or greatly reduced, to focus on their exercises to tweak the biomechanics so that as the medication wears off, the inflammation and the pain don't recur. Generally, degenerative discs, when symptomatic, are treated very successfully non-surgically. There are times, though, when the disc just doesn't want to get better with non-surgical means. So when this happens, what do? Well, there are some intradiscal procedures that have been attempted to address the annular tear. These include intradiscal electrothermal annuloplasty, disc biacplasty, intradiscal PRP, and there are some others. None of them have really panned out. So the gold standard when conservative care hasn't worked, and the patient is still with very significant pain and experiencing difficulty getting through their day, the gold standard remains a fusion surgery. The goal of fusion surgery is to remove the motion around the painful spinal segment. In select patients, an artificial disc replacement can be appropriate. Here, careful inclusion and exclusion criteria have to be met first. A clear benefit of artificial disc replacement is that you better maintain the motion of the spine. With a fusion surgery, other than the pain of the surgery and the recovery time from the surgery, the real significant downside can be that you remove the motion from the spinal segment, and then the segments above and below that segment have to take up that mechanical slack. So that is, the adjacent segments in the spine undergo the additional stresses that used to go through the segment of the spine that's now fused. Now, additionally, the painful segment that was fused is often one of the more mobile parts of the spine, like the L4-5 or the L5-S1 discs in the lumbosacral spine, or the C5-6 or C6-7 discs in the cervical spine. Those spinal segments are designed to take up the stress of their position, which is more mobile. When they're fused, those additional stresses are now going to have to go through the other segments that aren't used to seeing as much stresses, and now they're going to have not only their own stress, but also this increased stress, and so they're going to have the increased chance of having problems at those levels. And finally, of course, the more segments that you have to fuse, the greater the likelihood that there's going to be this problem at the adjacent spinal levels, because there'll be even more forces going through those levels. Okay, I hope you found this video on degenerative disc disease to be helpful. If you've enjoyed it and if you've learned something, please remember to like this video, subscribe to the channel, and tell a friend who might enjoy it as well, because that's the way that we can spread good health information and achieve good health outcomes together. As always, if you have a question or a comment for me, you can reach me at Dr. Cooper at princetonsjc.com, or feel free to leave me a question or a comment in the comment section of this video. Thank you very much.